Thank you and good morning, everybody. It's a pleasure to see you again. For those who are joining us today, we just a quick refresh. We had an amazing, intimate, all-day conversation between the 8 groups that are here today, sponsored by the Liberty Fund on Tuesday. We had yesterday afternoon an academic industry panels that I think tried to integrate each of these incredibly important players from industry along with academic colleagues, start to talk about ways we could work together and ways we are already working together. We had a keynote last night from Dr. Rodney Howell, a grand figure in the history of newborn screening to move us forward into the world of newborn sequencing. And I want to make sure at the very beginning, because we're very lucky to have with us representatives both here in the room and online from NHGRI and NICHD, as well as from NCATS. And certainly for the early work in this, as I'm going to remark in my remarks, these NIH supporters and visionaries have been absolutely critical. So if we could have my first slide here. Thank you. So the dream of universal newborn sequencing, as we've remarked thus far, in both humorous ways and serious ways, has been this almost this meme for 20 years. As the genome revolution has occurred, we've been talking about the day in which this would happen. And I want to talk a little bit about this from the point of view of BabySeq. And I think one of the things, since we are all going to be working with industry, we really should try to get into the habit of disclosing transparently all the sources of funding and support and that we're working on. So here are mine. And the program that I direct, we cheekily call Genomes to People. And it has recently evolved with the help and support of Ariadne Labs into a larger precision population health program, but it's focused on implementation medicine and genomics, and that really means the risks, the benefits, and the costs. And it's a relatively small core group, and the new PPH program is really led by Nick Encina, who's taken the responsibility for really pulling this consortium together and pulling this meeting together, as we acknowledged last night. And also Carrie Blaut-Zawatsky is a very prominent genetic counselor who's been key to that. But none of this happens in an individual program. We actually have been training mentees at every level, from high school to postdoctoral, even faculty scientists. We have been focused on diversity from the very beginning, with the first funded grant to offer subsidized elective sequencing to healthy adults who are of color, the first grant to return genomic results to African Americans in the Jackson Heart Study, and with BabySeq 2, the very first grant that I'm aware of to offer whole genome sequencing explicitly to African American and Hispanic newborns. And a lot of this grew out of the work that was funded by NHGRI early as part of the CSER project, and our contribution to that was the BabySeq Project, which was the first randomized trial of comprehensive genome sequencing in healthy adults. Excuse me. I'm not going to go through the years we spent on this and the over 50 publications, but one of the most startling observations that we made first among anyone was that when you look at over 5,000 disease-associated genes, 20% of ostensibly healthy adults were carrying either a dominant mutation or a biallelic recessive. Obviously, that didn't mean they all carried the disease, but when we circled back in light of that information, we found that a quarter of those were carrying subclinical or misdiagnosed features of the genetic disease. In the BabySeq project in adults, we discovered that you could, with some confidence, say that 20% of individuals were carrying these dominant monogenic risk factors. Over 90% were carrying at least one copy of a recessive allele. 80% had atypical responses to medications, for which we are all looking toward the world of pharmacogenomics. And we estimate that over 50% are carrying the highest level of risk in at least one polygenic condition. And this and other groups kicked off a series of really interesting conversations about population screening with genomics. And people came at it from very different directions. In some ways, our work on the 2013 ACMG recommendations for secondary findings helped crack open the door for this, because that was a kind of opportunistic screening where people who were already getting sequenced, we could recommend a list of first 56, then 59, and now about 78 genes that we felt were actionable, and actionable in a very concrete way. And when we did this, it was very interesting to watch the world move from skepticism all the way to embrace, sometimes without any pause in the middle at equipoise. And so at this moment in time, I don't know about your IRBs, we can't take something for genomic research to an IRB without having the IRB ask us, are you returning at least the ACMG list? And if not, why not? And so that's a really interesting sidelight that, we haven't touched on much, but I think has helped contribute to this. I won't spend a lot of time on this because David subsumed most of these themes. But this brings us to the BabySeq Project. Now, I don't remember the exact year, but in approximately 2009, 10, 11, there was a working group that the Child Institute and the Genome Institute put on together. And this, NIH sometimes gets a bad rap for, less creativity or less visionary, but these folks got in a room and said, this is coming for all the reasons we are talking about now in 2022. And they said, let's start funding a group of grants to try to explore this. And that became the Insight program. And there were 4 grants funded, and ours was, the BabySeq Project was one of them. And so Francis Collins, for example, has been talking about this forever. And I still remember talks where he would start with the first slide, right, with the baby, the figure of the baby and made up of DNA strands. And this is just one quote from 2012. And whether you like it or not, a complete sequencing of newborns is not far away. And yet here we are in 2022. And so the BabySeq 1 project got started with MPI Alan Beggs. And given the facility with which we're talking about launching all these projects today, I can only hearken back to what Rodney was talking about last night to tell you about some of the resistance when we got funded in 2013. The resistance, we had to go through 2 IRBs. We had people standing up at meetings and calling us down. The reviews, the anonymous reviews I got on papers and follow-up grants were absolutely devastating about how unethical and inappropriate this was going to be. And I can only tell you that the groups that we've pulled together for BabySeq have persevered in this. And today, BabySeq 2, the MPI is Ingrid Holm, who you're going to hear from a little later. BabySeq was framed as a randomized controlled trial. Now, obviously, this isn't designed to be the maximum for recruitment because people don't like randomized controlled trials. They don't like to want something and then find out they've been randomized not to get it. But the kind of people, all of our research from the very beginning made it clear that the kind of people who volunteer first to be in studies that are disclosing genomic results are information seekers, and they are different from the other sorts of people. They're different in their attitudes, they're different in their fears, they're different in their use of medical resources. So we're very proud that we persevered with this randomized clinical trial. Before we could do the trial, we had to come up with one of the first lists in the world. And we did so with Heidi Rehm and Hassan Birney. And we came up with a list of a little under 1,000 genes. And as a side note, we ended up reintegrating a few adult onset conditions into this list for reasons we can talk about later. We also actually did surveys, of course, many surveys to try to find out what people wanted. And what's fascinating, but you probably would have predicted, is that when you ask people simply, would you like your child DNA tested to detect a condition that might be treatable or save their life, almost every parent says yes. By contrast, as we were forced to do, when you bring a 14 to 16 page IRB, tell them you're going to randomize them into a randomized control study, you're going to draw blood from them, as we did in this case, make your brand new precious baby cry, and the best you can hope for is a terrifying rare disease that we may or may not be able to successfully treat, you get quite a different reaction. So as you would have imagined, framing this honestly, transparently, but positively is an incredible challenge as we go forward. And I think one of the most interesting things about these different groups will be how each of us do that. So we were not dismayed, but by the end of our recruitment, we found that about 10% of people really did want to come into this. Since we had reduced the 5,000 genes in MedSeq to 1,000 genes, we expected a lower percentage of positive monogenic findings. And indeed, we saw that. But we were still stunned that this represented 11% of the apparently healthy babies carrying a monogenic disease risk or, again, a biallelic. They were of all sorts. You can see a list there of most of them. And this is a real glass half full, glass half empty moment. If you are of the opinion that we're going to frighten parents and hang a sword of Damocles over their head and create patience in waiting, we certainly did that. But again, about a quarter of these, when we circled back through the lens of the DNA finding, we saw that they already had features of the condition. This to me was an entirely new concept. We weren't simply talking about indication-based testing of sick infants and predictive testing sometime in the future for healthy infants. We were also talking about DNA as a clue, as an entree into underdiagnosed or misdiagnosed infants. And this is a theme that in MedSeq and BabySeq and in our unanticipated return of results work through research, we've seen over and over and over again. It's not just about diagnosis. It's not just about prediction. It's about bringing genomics to bear on symptoms or signs that have been missed or misdiagnosed. I can't reinforce to you how important that is. And in my mind, transformational that is, because it's a whole new way of valuing the genomic screening experience. We also found, of course, that there were, if you do the whole genome, you can find many more recessive markers. And, I heard Wendy Chung yesterday talking about this as the low-hanging fruit of our era. And I really think it is too. I think that preconception screening, although complicated now with the state of reproductive health in our country and policies around that, is such an effective way to try to lower the burden of genetic disease. And so, let's not forget, as we focus on dominant and biallelic conditions for rare diseases that we can treat, and that there will be a lot of focus on with pharma support going forward, let's not forget how valuable it could be to make families aware of the recessive carrier traits that are going through their family. Now, there has been a narrative since the Huntington era of catastrophic psychological distress. There has been a narrative that you will terrify adults if you give them predictive or probabilistic information. You will terrify parents of children. We never want to be cavalier about the psychological distress that we might create for families, but starting with the Reveal project 15 years ago, going on to the PGen project where we looked at direct-to-consumer customers, continuing through MedSeq, and all the way through BabySeq, The power of our randomized clinical trial really comes through here, because among those individuals in every one of these studies, in the combined insight return of result, in the new emerge return of results, in all of these studies, every single one of them, the narrative of catastrophic distress has been rebutted. We should please put that to rest. Again, not to be cavalier, there will be people upset. There will be people very upset. But at least at this moment in history, the people who are volunteering for both the clinical trials, for the commercial opportunities, if properly informed of what they're getting into, are able to manage this information. They are self-selecting to manage this information well. And in this remarkable study, we looked and compared the people who received sequencing to the parents who did not receive sequencing, and looked separately at those who received a monogenic, unanticipated monogenic risk. And as you can see, there was literally no difference between the groups on any of these validated measures of distress. So today it's my pleasure to announce a small amount of new data from BabySeq. These are unpublished findings, so please consider them to be preliminary, but they've been out there in the public domain now, and you can talk about them. And as we have heard, one of the core questions is cost effectiveness. And we are very fortunate in the BabySeq Project to be collaborating with my former trainee and now independent investigator, Kurt Christensen, who is working at Harvard Pilgrim, leading a team of people who are doing microeconomics measurements. Again, this really helps us, even with a small sample size, to begin this process with a real control group. And Kurt has discovered, if you look at the central graphic there, that at least in the BabySeq Project, the participants who learned they carried a monogenic disease risk definitely spent more money following up those findings. Of course they would. We would find a cardiomyopathy mutation. That baby would need an echocardiogram. But to start to put error bars around this for one of the first times ever is to suggest that it actually isn't exhaustively expensive in our hands. And this was with the full weight of the Boston specialty community available to work up every patient at every turn. So this is encouraging news that at least in the first 10 months after disclosure, babies who learned that they had monogenic, unanticipated monogenic risks were not exhausting what has become known as the common wheel. We also looked at and evaluated with a core group of clinicians whether the follow-up was exaggerated or appropriate. Now again, this isn't real life. This is an academic community. This is an NIH-funded research study. But we did find that thus far in BabySeq, very encouraging suggestion that babies weren't being over-treated and over-surveilled. They were being appropriately treated and surveilled for these various findings that were there. And this is now up on medRxiv. I encourage you to go look at it. If you search medRxiv for BabySeq, it will pop up. We looked over the past 5 years now at follow-up, the first long-term follow-up of any cohort of newborn sequenced, apparently healthy newborn sequenced infants. And we counted up the specialty consultations, the ongoing surveillance, the imaging studies, the phenotypes discovered, the specific diagnoses that were made. And we found that there was a lot of activity. But when we put all these conditions into the ClinGen semi-quantitative actionability metric, all of them, every single one of them scored as actionable. And we didn't expect that, because these aren't the ones that have a pharma FDA-approved treatment ready to go. In fact, none of them do. These were actionable by those ClinGen criteria, and they were definitely actionable in the eyes of the parents and the clinicians who were following them. What really surprised us was the panel on the right. we, the genetics community, have tried for decades to get people to do cascade testing because that is the place where the prior probability is highest. But it's been resisted. My friends at Invitae say that in their view, 20 to 30% of people are actually following through on freely offered cascade testing. We found a much higher percentage of that in BabySeq. And I think there might be something, it might just be our cohort, but I think there might be a really interesting clue here that integrating genomics into a baby offers the entire family an easier path to cascade testing. And we found specialist consultations, ongoing surveillance, cascade testing, a variety of relatives, and three life-saving, risk-reducing surgeries because we had included from the ACMG list some adult onset cancer conditions. What could be better for an infant than saving the life of some of their adult family members, particularly their mother? We've taken a lot of arrows when we first launched BabySeq, but we've also benefited from a lot of attention, and we appreciate that. And we hope that we've tried to shape the dialogue with the media attention in a way that values a certain amount of enthusiasm and equipoise. And this is something, as we pull these 8 initial groups together, as we had our planning calls for this consortium and this conference, we started to talk about is how do we message? How do we message in a world where there will be enthusiasts, rabid skeptics? We're certainly academically self-interested, private companies that want to push the market, policymakers that might be conservative. How do we message within all this? And I think one of the early values of a consortium that we're forming is that we can reinforce each other's moderating messages. We can reinforce, hopefully, enthusiasm with scientific balance. So I really want to encourage all of us in our conversation, I think it's already started, to communicate that. I also want to say that we have volunteers from our studies that want to talk to you and want to talk to the media. And so this is Alyssa, whose son had a genetic heart disease risk identified in the BabySeq Project. This is Kim and Ken, whose daughter was tested with genome sequencing and were delighted that there was no monogenic disease risk found. This is an individual who gave us permission to use her photo, but not her name. She learned that she herself was carrying a completely unanticipated genetic cancer risk through her son's newborn screening. And this is Delante and Gabriella, who were randomized to the control group in BabySeq 1, but were so enthusiastic, they've joined our stakeholder board and are helping us shape the narratives, the dialogue, the consent, and the disclosure for BabySeq 2. Oh, and this is baby Cora and her mother, who have probably been willing to get out in front. This was the baby with a partial biotinidase deficiency who's been taking an inexpensive vitamin every single day since newborn screening missed, but newborn sequencing discovered that condition. So BabySeq 2 is the implementation of preventive genomics in a diverse cohort of healthy infants. I'm proud to announce today 2 new BabySeq sites that are self-funding, along with our NIH NCATS funded 3 sites, and those are CHOP and Beaumont Health in Detroit. We are moving this forward with incredible support from the Broad Institute and the Harvard Pilgrim Healthcare System. And in this BabySeq 2, we will be partnering with community clinics. We have already begun interviewing parents. We're training pediatricians to understand the kinds of results, though we're not expecting them to do everything on their own. We're validating various parts of non-invasive sampling, and very importantly, developing culturally appropriate materials, going from just a couple hundred participants in BabySeq 1 to over 1,000 diverse participants in BabySeq 2. The dream here is, of course, not to stop with newborn sequencing, but to have a replenishable resource, a resource that is reinterpretable at different phases of life, so that parents, perhaps, if parents really are our North Star, David, parents have a choice to get everything that can be gotten when the baby's born, or to learn things in a timed manner such that the science around everything they might learn is at its ripest at the moment that their child is reaching the age of that risk. And our small team at Genomes to People, our larger team at Ariadne Labs and PPH, is simply embedded in a very large team of collaborators whose names are too lengthy to all acknowledge. But I do want to at least show some of their photographs and mention that in the bottom right there, Casey Janetti and Bethany Zettler, who have been the extraordinary coordinators in BabySeq 1 and BabySeq 2. And they're here, and you should meet them at the breaks. So our program is here, and if you don't already have our social media handles, please feel free to follow us there. And like a lot of startups, we kind of imagined, oh, BabySeq, we can grow from BabySeq 1 to BabySeq 2 to the whole world. But obviously, there's a lot more going on than BabySeq. And so we started thinking a year or two ago about how does newborn sequencing grow constructively. And with Nick and Sina's leadership, gathered the folks here and hosted this conference. And I think the way we grow constructively is to grow together. And I'm so proud and so grateful to everyone that you're going to hear from who's been planning this with us, who's here and who are growing this constructively, so that the International Conference on Newborn Sequencing births an international consortium on newborn sequencing. Thank you very much.